So good afternoon, everybody, and welcome to Soteria's webinar on personalized diagnostic prostate MRI. My name is Jan Savic, and I am the CEO of Soteria Medical. We at Soteria have recognized the need to provide a platform for additional training courses by clinicians and experts during these challenging times. And this is why we have created this webinar series to at least partly compensate for all the canceled workshops, conferences, and congresses this year. Before I have the honor to introduce our two distinguished speakers for today, I would like to take just a few slides to introduce Soteria to those of you who are not familiar with the company. Soteria, that was too far. Soteria Medical is a spin-off from the Radboud University in Nijmegen, the Netherlands, and we are focused on developing products for MR-guided interventions. Our main product is the remote-controlled manipulator for in-bore MR-guided prostate interventions, and for this we are utilizing our patented motor principle. Our RCM has been designed for transrectal targeting of the prostate inside the MR bore. And for that, it is fully MR compatible, meaning it's entirely made out of plastics. And we use pneumatic drives for highly accurate positioning under MR image guidance. Soteria now has, Soteria now has installations all across Europe. And we have also expanded into other markets across the world. Our latest installations have been to India and most recently to the United States, where we just installed a system at Mayo Clinics, Arizona in the last month. If any of you are interested in more information or would like to get in contact with our clinical reference sites here, please contact us. We also will be able to provide online demonstrations of our product if you are interested. So again, please contact us or our distributors, and we will be organizing that. Before I move on to the introduction of our speakers, a few household items. All participants except the presenter will be muted for obvious reasons. For general comments, please use the chat button at the bottom of your screen. For questions, please use the Q&A button. So if you type your questions in there, after each talk, we will try to answer all of your questions as best as we can with the help of our two speakers. For which I would like now to use the opportunity and introduce our two speakers. I'm very happy and proud to have Dr. Villanova and Dr. Petralia here to give our clinical talks today. Dr. Villanova, as you can read, is the chief of the Department of Radiology at the Clínica Girona, a consultant at the Catalan Institute of Health, and also a professor at the Faculty of Medicine at the University of Girona in Spain. And Dr. Petralia is the director of precision imaging at the research unit of the European Institute of Oncology in Milan, Italy. Both of them have many years of experience in the field of diagnostic prostate MRI and interventions. Both of them have published numerous papers in the field and are internationally recognized speakers. And with that, I would like to ask Dr. Villanova to start our first talk of today.
Okay, thank you very much for this introduction. I'm going to share my screen now and start my talk. First of all, I'm happy to participate in this webinar. So my talk it will be how we can detect this lesion, because this is going to be, of course, the first step. The second step it will be Dr. Petralia, how we are going to place the needle in this lesion that we have detected on MRI. So first, I have no conflict of interest. And after a brief introduction, I'm just going to have a brief remind of how important, of course, before we can detect an optimal, an accurate lesion, we should perform an optimal MRI. Otherwise, it's not possible to detect a lesion. Once we have an optimal MRI, then it's time to know what are the criteria to detect this significant lesion, according to the guidelines that we should know, and we should follow these guidelines. Once we have detected the lesion, it's going to be very important to report effectively this information. Otherwise, again, it won't be possible to place correct a needle. So this is going to be my talk, how we are going to plan the information detecting, and then Dr. Petralia is going to show how we are going to place the needle in the proper location. First of all, just latest news, latest data, important data. As you can see, just 4 or 5 days ago, last weekend, from the ASCR meeting, relevant data that provides again how important it is to perform an MRI. Here is the study, what is called the Prostate study. What was the purpose of this study that has been performed by the Imperial College of London? The objective of this study was, we know that for now, the screening test for prostate diagnosis is PSA. We know how bad is this test. So the purpose of this study was, how can be perform a screening test using a short MRI, 15 minutes MRI. There was 411 men, and they performed PSA and a short MRI. Whether the PSA was positive, that means that over 3, and whether the MRI was positive, that means over 3 or 3, then those patients had biopsy. What was the result? Here we have, whether the PSA was positive or against the MRI positive, considering positive in this case, whether we have a PIRATS over 3, that means a PIRATS 4 or 5, the biopsy rate is similar using PSA and using a short MRI. The detection of significant cancer is higher in the MRI. Significant cancers are missed most in PSA. There is no difference according to the non-significant cancer detection between PSA and MRI. Higher detection, significant higher detection with MRI. So again, more data that we have a tool that detects better significant cancer. We know how difficult, and this is the reason that we are here and we are performing this webinar, because it's a great challenge to diagnose a prostate cancer. And we know how difficult it is and how the health problem concerning prostate cancer due to the main reason. It is a very common cancer, but a very, very low mortality. And this is because we have 2 types of cancer. There is one cancer that is benign. It should live alone. It should not be detected, this cancer, because otherwise we know this cancer, that means a Gleason 6, this is a benign disease. On the other hand, of course, from a Gleason 7, this is a significant lesion. And this is the main challenge that we have to face with our tools nowadays. Because for decades and decades ago, we know how many blinded biopsies have been performed and unfortunately still are being done. We know how low is the detection of prostate cancer using this method. And not even that, the chance to detect the non-significant disease, that this non-significant disease is overtreated then. The lower chance And there's going to be a lot of negative biopsies using this system that has been performed for decades and decades. Unnecessary biopsies, what it is obvious. How can be treated something that is not seen? And this is obvious. That we have MRI. MRI is going to see something, not in every sequence. This is why we have to apply the power of the sequence, the diffusion, where I see this high signal 7 millimeters lesion. And then it's time to plan to place a needle here using diffusion. And at the same time, I'm going to plan with the ADC. I know this is the lesion that I should move my guide and finally place, and I know that the sample is going to be from this exact lesion that I have planned. One needle, I have the Gleason 3+4 in this patient that has had 2 previous negative biopsies. And this is the main issue, because I'm going to have higher detection. I am going to avoid to diagnose a non-significant disease. And this is the big change since some months ago, because guidelines have already included that any patient is not going to biopsy without an MRI. And this is the new paradigm to diagnose a significant lesion, using MRI before any biopsy. And this is due to several studies. One of the studies that have performed this changing paradigm is probably, most of you know, the precision study. Just the data that it allows us to avoid to perform biopsies, whether MRI is not positive. With the positive and the target biopsies, we are going to detect more significant cancer than the systemic biopsies, and we are going to detect less non-significant cancer than performing the systemic biopsies. This is just some data, and even recent data from more than 5,000 evaluation from 20 studies that have been performed with a systemic review some months ago from recursion database, is just the same or similar results that it was from the precision study. So this is the data that it provides us the evidence that we should use MRI to detect significant lesions. And how we are going to detect significant lesions? Using properly the guidelines. And this is the guidelines updated also 1 year ago to version 2.1. Before we can read the MRI, we should perform optimal MRI. I'm just going to a brief remind of the technical issues important. We can use even 1.5, even 3 Tesla, of course, better 3 Tesla, but if we are using 1.5 optimal coils, high resolution T2, and the key sequence for our detection is going to be diffusion, but not a simple diffusion, high power diffusion. And also, as we are going to review, diffusion has to be at the same time as we are analyzing ADC. But this ADC has to be processed from a not so high B value. So if we cannot compute diffusion, we have to acquire 2 sequences of diffusion. One, not so high, because it will be our image of ADC. And the second one with high B value, which is going to detect the significant lesion. And this sequence also, diffusion has to be from the whole pelvis, not only from the prostate, because we have also different indications for diffusion. Of course, T1 from the whole pelvis, and as we are going to review, minor role for the detection of contrast. But if we are using contrast, it has to be used with high temporal resolution. Here you have a paper that it was published after the new PIRADS update, where there is all the technical details from 1.5 and 3 Tesla with the proper technical parameters that it has to be achieved in any acquisition of optimal prostate MRI. So once I have an optimal MRI, it's time to the main objective, to detect the significant lesion. And I'm going to score whether the patient is going to have from very low chance to high chance that has a significant cancer, because the objective is to detect a significant cancer. That means a Gleason 7 or higher. And this is the main objective to read an MRI. We know that we are going to omit significant cancer. Of course, this is a limitation, but it's better this limitation than not having an MRI. That it was, and it has been, patients without any imaging, and as we have seen, only 45% of cancer detection. Using MRI, at least 70% detection. So that's the issue. We know that we are going to lose and we are going to omit significant cancer, of course, but less than not having an MRI. So this is the main challenge that we have to manage our patients, because whether the MRI is score 1 or 2, we are going to avoid the biopsies. And whether the patient has a PIRADS 4 and 5, this recommendation is to have the biopsy. What about the PIRADS 3? Well, this is the challenge. But here we have more data with the patients, because the same image on a PIRADS 3, different manage. Why? Depends on the patient. I'm not going to have the same management with the same PIRADS 3 score with a patient 80 years old with previous negative biopsies and with a low PSA density. This patient, even I'm not sure that it's a discrete signal intensity, I'm going to follow up. The same PIRADS 3, the same image, with a 50-year-old patient without any biopsy. This patient, I will recommend biopsy. So, same image, different management. How I'm going to score the image? Well, I'm going to score from 1 to 5, but the big decision is to localize where is the lesion. Because my criteria with a transition zone lesion, I'm going to score with the criteria of the T2. A lesion on the peripheral zone is going to be scored with the criteria of the diffusion. And finally, I'm going to provide the final score and different management where there is unlikely that the cancer is present or likely that the cancer is present. Then how I'm going to assess? As I have already said, the important to localize the lesion, because if the lesion is in the peripheral zone, the score that I'm going to provide, as we are going to see this, the criteria for the diffusion, it will be the final score for the PIRADS. Whether the lesion is in the transition zone, the score I'm going to provide on T2, it will be the same final score. Minor role for the contrast. There is only minor role whether I have equivocal lesions on the peripheral zone. No role for contrast on the transition zone. And very important role for diffusion, of course, not only in the peripheral zone, and as we are going to describe, very important role now also in the transition zone from PIRADS 2 and PIRADS 3, as we are going to analyze. Again, minor role for contrast, but we have to know what is the criteria for the contrast. Criteria for contrast, it's only a binary decision. That means negative or positive. But even negative, this does not mean that there is no contrast engagement, because there might be enhancement, but if it's not early enhancement, this is negative. If it's diffuse enhancement, not corresponding to the focal lesion seen on T2, this lesion on the left side and the contrast is diffuse. So this is negative contrast. or any other enhancement lesion of a BPH lesion. What is positive lesion? It's only whether there is early uptake, whether it corresponds to a focal lesion either on T2, either on diffusion. So this is the criteria for positive, negative contrast. And very important criteria for the nodules, the BPH nodules, because the C is going to be key in our analysis of the transition zone. And this has to be analyzed carefully, because we know that a nodule can be, most of the time, is going to be mixed. Why? Because it depends on the quantity of the glands. Higher quantity of glands, higher signal. Higher stromal area, lower signal. So most of the times it's going to be mixed, but the important issue is the encapsulated low signal intensity rim, because the nodules might be restricted, might enhance, but the key decision is encapsulation, beside restricted diffusion, beside any uptake. So we should follow the criteria. Whether I have a lesion on the peripheral zone, I should go for the criteria for the diffusion. Whether there is nothing on diffusion, nothing on ADC, be aware that this N, very important. Because then, whether I see something on ADC or nothing, and be aware this is N or. So whether I see something, this might be, it's going to be a 2. Where I'm starting to see some focal area, discrete, be aware that the signal has to be discrete from the background. This is discrete, but what is going to be very important here, that has to be focal. So be aware that if there is nothing focal on diffusion or ADC, never can reach a 3. It will be as high as a 2. So the important issue is to find something focal, because this is going to be, or to start our PIRATS 3. And important that it has to be in high p-value, as we're going to analyze. Otherwise, we are going to not detect significant lesions. And it can be something markedly on PIRATS 3, but not in both. Because of course, whether I have a PIRATS 4 has to be, look at N, it has to be in both images. Very important, as we're going to analyze at the same time, high signal, low signal on ADC, beside what I see on T2. Because on the transition zone is completely different criteria. Now, what is going to be benign is something focal. And of course, it has to be encapsulated. And whether there is not completely encapsulated, it's going to be a 2. But it's going to depend whether there is restricted diffusion, because whether there is markedly restricted diffusion, this is going to upgrade a 3. And whether I have either heterogeneous, either lenticular, it's going to be, then it's going to be PIRATS 4 or 5 according to the size of the lesion. So it's very important to read properly. Any patient has had biopsy, we should read previous T1, because there might have hemorrhage, and it's going to interfere in my signal intensity, probably. So be aware, any patient after biopsy, we should read previous to any PIRATS reading the T1. We should review at the same screen all the different sequences, T2, diffusion, and ADC. We should adjust properly. We should provide that we know that we have the image with a high p-value, and we have to localize the lesion and read where the lesion is in the peripheral zone, the diffusion, whether there is a lesion might be focal, and find the rim whether we are with a nodule in the transition zone. The final decision whether the patient might have high or low probability that has a prostate cancer. And then we have to localize from the segment of the template of the map of the PIRATS that we have to include in our report. Because here on the T2, we might not see any significant area. Not either here on the diffusion, but this is the same diffusion. The big difference is that this is high B value, this is lower B value. So the same patient, we can see that I would score a PIRADS 2, and this patient has a significant lesion because I have to read the high B value. Otherwise, I'm not going to detect the significant lesion. I have to display the 4 sequences. I have to adjust properly, markedly low, markedly high. I measure on ADC, and before any reading, if the patient has a biopsy previous, read the T1. Then I am going to start with the periphery. If the periphery is nothing focal, the transition zone is homogeneous, or something completely encapsulated, this is going to be a PIRADS 1. If there is something in the peripheral zone, but nothing of restricted diffusion, this is going to be a PIRADS 2. Whether we see something discrete focal, I might apply contrast, but if the contrast is diffuse, this is negative. So this is going to be a PIRADS 3. Whether I see some discrete signal intensity, but the contrast is positive, this is a PIRADS 4. Of course, whether some lesion is markedly high, markedly low, this is a black and white, and this is going to be a PIRADS 4 or 5, depending on the lesion size. And in the transition zone, if it's not completely encapsulated or is homogeneous, then I have to apply with the diffusion. If there is no restricted diffusion, this is going to be a PIRADS 2. If it's restricted diffusion, completely markedly high, markedly low, this is going to be a PIRADS 3. And then, according to the ill-defined lesion, if it's heterogeneous, then it's going to be a PIRADS 3, and the PIRADS 3 should apply diffusion. If there is no restriction, or there is restriction less than 1.5 centimeter, this is a PIRADS 3. Whether heterogeneous lesion with markedly restricted diffusion higher than 1.5 centimeter, this is a PIRADS 4. Ill-defined lesion, lenticular, less than 1.5 centimeter, this is a PIRADS 4, and higher lesion, it's a PIRADS 5. So, very important to provide where is the lesion, detect with the proper sequence, and to know the criteria. And then, this is the algorithm that one should have in the desktop, whether we are reading the prostate MRI. And the final step, we can read very well, but if we are not going to provide proper information, our communication is not going to be effective, and the patient is not going to be managed well. And most important, it's not going to provide a target biopsy in the specific location. So this is going to be very important, that our report should include all the information, because management of the patient is going to depend on our report. And we should display at the same time all the sequences. Different softwares help us to have the checklist, whether I'm measuring the lesion, I might quantify the ADC, I'm going to provide where is the lesion in the map included, and then I'm going to score the lesion and the final PIRADS. I'm going to provide different comments, because if I suspect that this lesion is going to be, even I don't know still that there's going to see a prostate cancer, but what is going to be important is to provide also the staging. And I'm going to send this report either to the PACS, either to the print, either to generate a PDF with all the information. Quantitative information, where is the lesion, and very important to include images, because then it can be perform a proper target biopsy. So this is going to be our main accurate detection lesion, to read properly with the guidelines, with acquire optimal MRI, read the significant diffusion, know all the criteria, and report effective all this information, because it has to be performed at the end an accurate biopsy, a target biopsy. Because this patient has had previous adenomectomy 5 years ago. It has had 2 years previous, 2 different negative biopsy, rising PSA, not quite as specific the T2 again, very, very high restricted diffusion. Then I plan the biopsy. I know that I should guide the needle in this specific location. One needle, one sample, it's enough for a Gleason 4+3 in this third biopsy, but target biopsy in the specific patient. So in the near future, I'm sure that prostate will have what every organ has, not to biopsy all the organ. I don't know any organ that is being performed what is being done with the prostate. Why the prostate? That because now we have excellent tools to avoid to biopsy all the organ. One target, one sample could be enough for our patients. And that was what I wanted to provide the information to detect a significant cancer. Thank you for your attention. And I don't know if now we could have any questions.
Thank you so much, Dr. Villanova. That was a very interesting and very informative talk. We didn't actually get too many questions on the Q&A, so I would encourage everybody to please use the Q&A button at the bottom of your screen to ask any questions. We had some questions up front that have been submitted by some of the registrants. So I would like to maybe use the opportunity to ask two of those to both of you, of course. One question is from a participant in India, and he states, in India, we don't have prostate cancer screening, and our caseload only constitutes symptomatic patients and those referred following a prostate cancer diagnosis. We use biparametric MRI for prostate with T2 and DWI, and we use contrast only for problem solving. What would be the indication for dynamic contrast enhanced MRI in our setting? Please, both of you, maybe Dr. Villanova, if you could start.
Yeah, well, this is quite a topic concerning biparametric or multiparametric, of course. But what is, and for me also, I'm performing biparametric. So in the indication according to the PIRATS is when we have a PIRATS 3, but of course, different papers that whenever one has quite experience on prostate MRI, contrast can be avoided at certain point. So most of the times it is reasonable to have a biparametric prostate MRI. And concerning what this attendant was saying about that in India there is no screening, but of course there is not accepted screening for the prostate. Although we know that it's a kind of pseudo screening that patients can have a PSA at a certain age. So of course in Spain also there is no accepted screening, but at the end this is more or less that the PSA is after a patient has a 50 years old. A lot of patients will have a screening test. Okay.
Right. And Dr. Petralia, your view on the use of DCE?
Yes, as correctly it was pointed out, it depends mostly on the population where we do multiparametric MRI. So in India, for example, as it was requested, they only see, as I can understand, the symptomatic patients. So probably they see patients with a larger cancer than what we see in Milan and Italy, where we have some sort of screening with PSA. Therefore, in that particular case, I think a contrast agent is less important because the cancer are supposed to be big, to be symptomatic. So when you see a bigger cancer, the importance of contrast is less.
Mm-hmm. Okay, thank you. I think that's a very good answer from both sides. There's another question that was raised previously and now comes back up in here, which I would like to ask both of you, because I know that you are using a 3 Tesla system now, Dr. Petralia, but you're using a 1.5 Tesla, Dr. Villanova. So could you give us your thoughts on using 1.5 versus 3T on diagnostic prostate MRI?
Well, I'm using 1.5 because this is what I have. If I would have a 3 Tesla, of course, I would have next year we are acquiring a 3 Tesla. So if this web seminar will be in 1 year time, I will say I'm using a 3 Tesla. But since now I'm still not having a 3 Tesla, I'm using a 1.5. And as I feel more confident with the undirected coil because I have more signal, I like the high B value for the detection. So this is still my confidence to undirected coil 1.5 Tesla, and I feel very confident in my examination. Yes.
So I can add on top of that that we had a very long experience on 1.5, and we were very happy of our 1.5. Then 2 years ago, we moved, 1 year and a half ago, we moved with a good 3T system. And in our experience, I can say that, of course, we get images, better images. They're superior in terms of quality. And the signal, the gain in signal, we invested all in image quality. So we have much higher resolution. And you can see the difference both on T2, on diffusion, it is perceivable. However, it's not always, it's not everything perfect on 3T because the images are very sensitive to gas artifacts. So we should pay more attention to avoid gas into the rectum on 3T more than the attention we used to pay on 1.5. Second point is 3T sequences are more affected by movement artifacts. So we should train the patient in a better way. And last but not least is the protocol. To setting up a good protocol is quite challenging because you have to take into account all these possible artifacts. And so at the end of the day, we have a better image quality with more artifacts, and the time is more or less the same.
Okay. I think that's very nice, extensive answer on this question. I think we would like to move on to Dr. Petralia's talk for now. There are more questions coming now, so we try to answer that after Dr. Petralia's talk. The questions that we won't be able to answer today, we will answer in writing to everybody after today's webinar. So please keep asking questions, and Dr. Petralia, please take the stage and
okay, I'll do my best to share the screen.
Thank you.
Okay, share the screen. Okay. Do you see it well?
Not yet. I think you have to select the correct monitor or program when you share screen.
Okay. Now?
Yes, that is. Thank you very much.
Okay, very good, very good. So my talk, I will start where Kai has finished this talk. Once the diagnosis is made, then we need to stick a needle somewhere. And I would like to start my talk with some evidence. And what is better if we talk about evidence from a New England paper. This paper published in 2018 was the result of a multicentric randomized trial, actually a non-inferiority trial. The authors compared the MRI pathway, which means if I have a patient with a suspicion of prostate cancer, so by that I mean elevated PSA or a positive digital rectal examination, they do on the MRI pathway, they do MRI. If MRI is negative, by that I mean virus 1 or 2, they just do follow-up. If MRI is positive, virus 3, 4, or 5, they do a target biopsy. And they compared this MRI pathway with the standard arm, which means any clinical suspicion of prostate cancer, patients do standard biopsy. 250 patients each arm, roughly, and the results were quite important because they observed a significantly higher number of clinically significant prostate cancer, 38% compared to 26%, and a significantly lower number of insignificant prostate cancer. By insignificant prostate cancer, I mean Gleason 3+3 that no one wants to diagnose. And after this evidence, there were other papers showing a similar observation, similar results. They compared the foreign study, the MRI affairs, all with hundreds of cases. They have shown that if we follow the MRI pathway, so if MRI is positive, we stick a needle in the target lesion, we do not lose any clinical significant cancer. In some cases, we detect more, but for sure, we reduce the number of insignificant prostate cancer, which is overdiagnosis. And therefore, guidelines had to take into account all these evidences from previous paper. And starting from last year, in 2019, they introduced the concept of target biopsy. So what do guidelines say today, 2020? That we must perform MRI before any biopsy with the level of evidence 1A, with a very strong evidence. So it means that once we have the result of MRI, if the patient is biopsy naive, they suggest to perform both targeted and systematic biopsy. While if the patient has had a previous negative biopsy before, then in this particular case, we can only perform target biopsy. So we have two different scenarios. If we have to biopsy naive patient, guidelines say to perform a targeted and systematic biopsy. The most practical system in our experience at our institution is the MRI fusion guided biopsy, because in this case, you can do in the same sitting both systematic and targeted. Okay, we are radiologists, we all know that any image registration is a potential source of errors. We know that the fusion of the images basically means to bring the MRI image into the ultrasound scanner. We know that any image fusion is a potential source of errors. However, it is far better than a standard biopsy. But if you are in the situation where the patient has had a previous negative biopsy before, then we can do target biopsy alone. And we know in our experience, there is increasing evidence in the literature that the most precise technique is the MRI guided biopsy. This paper, which has been recently published, compared the results of MBOR biopsy compared with the fusion biopsy. 100 patients for the first group, 300 patients for the second group. And the authors observed, it has been published last year in the European Urology, the authors observed that the patient with the MBOR biopsy, they had a significantly higher number of clinically significant prostate cancer and a significantly lower number of diagnoses of Gleason 3+3. And they compared also the upgrade, because we know that when we read the Gleason score of the biopsy, sometimes it's different from what we read of in final histology. They observed a slightly lower upgrade with MBOR biopsy than with fusion biopsy after surgery. And just going to more in depth into the topic of MBOR MRI guided biopsy. We have experience with two systems. The first system we installed in 2014 is the manual system. Basically, the patient, as it is displayed in these images, okay, you see the laser. The patient stays in the prone position on the MRI bed, and the introducer is inserted into the rectum, and then it is connected to the device. The device has the possibility to make movement in 3 directions. Each movement is dictated by an image registration software that it is provided along with the system. So basically you acquire MRI images, and by this image registration, after this image registration, the software tells you how many degrees right, left, up, and down, move your introducer to stick the needle in the right position into the target. However, it happens that the coordinates provided by the software are not always precise. And I would say often are not precise. So you stick the needle as in the image you can see in the left, and the needle is not in the lesion. But with this system, we have the possibility to do the MRI image of the needle itself, as you can see here. As you can see in this example, the first sample, as indicated by the software, that was in the pink circle, that was the lesion, the target lesion, and the needle was not inside the lesion, you can see here. Then you have the possibility to manually adjust the trajectory of the needle, as we did in the subsequent course, and then you see the needle that it goes directly into the lesion. By doing so, we observed that this is for now our first case. By doing so, you can really improve the outcome of your biopsy. We retrospectively evaluated our first 400 cases performed with this system, And we observed that our diagnostic rate was 56%, so 225 prostate cancer. But we observed that we would have been able to diagnose only 117 if we had done only the first core. While by adding additional core B, C, so 2, 3, 4 cores, we had the diagnosis of additional 108 prostate cancer. So by manual adjustment, in our experience, we increased our diagnostic rate of 92%. Then we move to the next system. Now there's been a couple of years, we are working with the Soteria system, which is a robotic system. Basically, as you've seen, is a pneumatic robot with 5 robotic arms, which give more freedoms of degree. And it has a beautiful feature in the image registration software. It displays the projection of the needle, so you can really move your introducer and see if the projection of the needle goes exactly into your target. So you are more confident when you stick the needle that your needle will go exactly into the lesion. And that was our feeling, but we wanted to test formally. So we compared our results on our first 400 cases with the manual system. And we observed over the first 400 cases a good reduction in time. Our average time for performing the procedure with the manual system on our first experience in the first 50 cases was 54 minutes. Then after 400 cases of experience, the time went down to 34 minutes. But then when we started with the new system, so we started a new system, but with no experience with the new system, we started already with 29 minutes, which means that the system was very easy for us to understand and very practical. And here are our results overall up to February this year, almost 700 cases. As you can see here, you see next that the number of significant cancer which are represented in red progressively increased by the increase of PIRAS score on the MRI. So now let's see which are our clinical key indication for performing in-bore MRI biopsy, which I'm happy to share with you all. First main indication, we do in-bore MRI biopsy when a patient has had a previous negative biopsy before and still has a positive multiparameter MRI. Our second indication, we do in-bore MRI target biopsy also in biopsy-naive patients, but not in all of them, but only in selected cases after discussion at our MDTs, multidisciplinary meetings. Last but not least is when we like to perform a reclassification of a suspicious case. Just see a few examples. The first indication, the main indication, as it is said by the guidelines, we need to perform a target biopsy only if a patient has had a previous negative biopsy. And why do the guidelines say this? Because it has been demonstrated, if you read the Cochrane meta-analysis published last year, if we add the standard biopsy to the target biopsy, we can diagnose 2–3% more clinically significant cancer that would have been missed with the target biopsy. In other words, it means that we need to perform 37 standard biopsy to find one significant prostate cancer more than target biopsy. So it is not worth the efforts. That's why guidelines say just do target biopsy if the patient has had before a negative systemic biopsy. And here a practical example. 70-year-old man with PSA of 9, digital rectal examination negative, and he had a negative biopsy with 1 out of 14 cores with ASAP. So we did MRI before any red biopsy, and we found actually a small cancer, a PIRAS for lesion of 4 mm in the left peripheral zone. Then we did target biopsy, in-bore target biopsy. As you can see here, the first core was just next to the lesion, but not into the lesion. And the report, as you can read below, the report of the pathology was normal parenchyma. While when we did some manual adjustment, 3 additional core, B, C, and D, you see here now the needle is exactly well positioned inside the lesion, and that's why the pathological report was Gleason 3+4. Second indication, as we said, yes, we do inbore MRI target biopsy, also in biopsy naive patients, but only in selected cases. Who are they? Patients with PARS 3, 4, and 5, if they have a lesion which is below 10 millimeter, and or if the lesion is positioned in a difficult site. And by that, I mean anterior apex, very cranial lesion who are difficult to reach, or in some cases when the prostatic gland is very, very big. And why we need to pay attention to select well the cases? Well, because in this particular condition, the risk of missing significant cancer, according to the Cochrane meta-analysis, is 4 to 5%. So it means, in other words, that we need to, in this condition, this setting, biopsy naive patient, we need to perform 20 standard biopsy in addition to the target biopsy to find one more significant prostate cancer. This is what is said by the Cochrane meta-analysis 2019. But June this year, on the Journal of Urology, Goldberg and other colleagues published another meta-analysis, bigger one, more than 13,000 patients, showing that if we avoid the standard biopsy, for sure we will have a lower rate of significant prostate cancer. So less diagnosis of Gleason 3+3 that no one of us want to diagnose, but this will not affect, in that meta-analysis, the rate of clinically significant prostate cancer. In other words, they say that it is still safe to perform just a target biopsy. Just to see an example, a 65-year-old man, PSA of 3.2, but rising over the year. Digital rectal examination was negative. We did MRI, multi-parameter MRI. We saw a very small cancer, a PARS 4 cancer, 5 millimeter, in the anterior horn of the peripheral zone. That was very difficult to catch with any technical biopsy. We did inbore MRI guided biopsy, and we had the diagnosis of a Gleason score 4+3. 3 out of the 3 cores. The patient was operated, the panel histology confirmed a 4+3, and disclosed that the patient was already a PT3, even with such a small size, the cancer was very aggressive. Here you can see the specimen, you see the hematoma, here the apex, the anterior aspect where we were performing the biopsy, and here the whole mount section. Last but not least, the reclassification, because our effort is to personalize the treatment according to each patient need. And so sometimes it happens that we find a patient who has a biopsy, a standard biopsy with Gleason 3+3. Then we read the MRI and we see some adverse features suggesting, for example, primary Gleason 4, restricted diffusion or a larger area, or maybe undiagnosed T3. Then in that particular case, we should reclassify the patient. And I give you, to make it very clear, I give you an example of our case, a 70-year-old man, PSA 7.9, digital rectal examination negative, and a biopsy which was positive only on the right side, 3 out of 14 copies. So this patient, in theory, according to European guidelines, this patient would be a perfect candidate for active surveillance. Then we did multi-parameter MRI, and we saw, I hope you can see my pointer, we saw a PARS 5 lesion in the central zone, which is quite difficult to catch, but there was, I guarantee there was a lesion here, I'm pointing it out. That's why we discussed the case at the MDT, and we asked for an inbore MRI biopsy. We did it, and as you can see here, there's a lesion here at the base, and the central zone, which is somehow infiltrating the seminal vesicle. We put the needle, as you can see here, inside the lesion, and the result of the biopsy was a Gleason 4+3. The patient, therefore, was for sure not a good candidate anymore for active surveillance. He went directly to the operating theater. It was performed a nerve-sparing bilateral robotic-assisted prostatectomy, which confirmed the Gleason 4+3 and confirmed also our suspicion of seminal vesicle infiltration, by a final pathological stage of PT3B. Everything looks beautiful with MRI guided biopsy, but real life is not. In real life, not everything is beautiful. There are still some controversial areas in this topic, and I'm here also to highlight benefits, but also drawbacks of this technique. For example, the number of cores. There is no agreement in the literature, in the urological, radiological, MR community, how many cores should we stick into a single lesion. There has been one paper published last year by members of the steering committee on radiology 2018, saying that they accept the concept of focal saturation. By that, it means that you stick a needle in the lesion and in the penumbra. Penumbra means probably the area around the target, but it was, to be fair, it was not clearly described in the paper what penumbra is. So, yes, the concept of focal saturation is growing. There are publications on this topic, but there's no agreement on the optimal number and what is the spatial distribution, where to put the additional needles. In our small experience, we are trying to address in our institution this problem. So we retrospectively evaluated all the cases that we perform with the manual system 414 and all the cases that we performed up to now with the robotic system. And out of them, we retrospectively took those who performed a sort of focal saturation. And by that, I mean at least 3 cores into the lesion, because as you saw before, we never do one single core in the lesion, but we do at least 3 now. And so we selected 219 patients for the first group, for the manual group, and 81 patients for the second group, who did at least a focal saturation with at least 3 samples in the single lesion. And here are the curves. What we observe is quite interesting. You see here, just follow with me the blue line, which stays for the manual system. By increasing the number of cores, you increase the rate of diagnosis. So it means that we were able to diagnose all prostate cancer after the 4th sample. Beyond the 4th sample, so in patients who did 5, 6, 8 samples, we had no additional diagnosis of prostate cancer. But if you look to the red curve, which stays for the robotic system, we see that it has a slightly different shape. We see that we observe that we did not make any diagnosis of any additional prostate cancer beyond the 3rd core. So in our experience, in our retrospective experience, we can say that the optimal number for focal saturation in our experience in our center was with the robotic system of 3 samples and with the manual system with 4 samples. Then there is another big point, the biological equivalence, which is a nightmare since decades, because we know that there is an upgrade. It is common experience that the patient receives a Gleason 3+3 in the biopsy, for example, and then after surgery it becomes a Gleason 3+4, 4+3, and so on. So there was a beautiful paper that tried to address this topic, published recently on the New England Journal of Medicine. They took 404 prostatectomy patients and they compared the results of the biopsy with the whole mount histopathology after surgery. They observed that the upgrade of Gleason was of 41% if they considered just the standard biopsy, of 30% if they considered on the same patient the target biopsy, and of 14% if they considered data from standard biopsy plus target biopsy. So this means probably that if naive patients perform standard biopsy plus target biopsy, they have less chance to be upgraded after surgery. And the results of this paper more or less replicate what is common experience. What we observe here, we have an upgrade of about 30%, and what has been published in other publications, where the upgrade is 20, 25, 30%, the Gleason. So what you see on Embora MRI, then it is upgraded by 30% after surgery. But we broke down our results. We have overall 30% of upgrade. But we understood by breaking down our results, that the majority of the upgrades are, in our experience, in our series, in the Gleason 3+3 group, because in that particular group, we had an upgrade of 64%, while, quite surprisingly for me, there was a very good concordance between 3+4 and 4+3. I was convinced that that was the most dangerous category, but that was not the truth. And also we observed some downgrade in the higher Gleason gradient, 4+4, 4+5, which became 4+3 and lower. So let's take the attention to this big group. 64% of upgraded 3+3 is really not reliable. This may lead to a big problem. It is called Will Rogers effect. Will Rogers was a humorist, American humorist, very famous. He became famous for this phrase. When Hokies left Oklahoma and moved to California, they raised the average intelligence level in both states. So this may look paradoxical, but I will try to explain you by the example if we translate it to prostate cancer. Let's say that we have in the yellow group, just follow me in the pointer. In the yellow group, we have a low-risk patient. If we use all the technology, and all technology, I mean, we just do standard biopsy. We have, for example, 10 patients who are Gleason 3+3, and they are all categorized as low risk. On the same patient, if we apply the modern technology, by that I mean MRI and the target biopsy, with MRI, we're able to see small lesions, 4mm cancer, that are focused, that are small foci of Gleason 4. So we're able to see a 4mm focus of Gleason 4 with MRI, and then we're also able to catch it by target in-bore MRI target biopsy. So it happens that those patients with the new technology are correctly diagnosed as a Gleason 4. So they're removed from the low risk category. As a result, the average survival for the low risk will be higher because there's a patient with small foci of Gleason 4 have been moved to the intermediate risk group. And then we will have an increase in the survival in the low risk group. But also we will have an increase in the survival in the intermediate risk group because there will have the patient with a large Gleason 4 that are diagnosed with the standard system, plus the newly diagnosed, the patient diagnosed with small foci of Gleason 4 that are now in the intermediate risk, but they have low volume cancer, so for sure they have a much better survival than the big Gleason 4. So it looks paradoxical, but with the Will Rogers effect, we have the so-called stage migration, and we increase both the survival of low risk and intermediate risk. And we can explain this concept further if we just look at the images. The images on the image on the top left shows a cancer, a hypothetical cancer, which is green. What is green is a Gleason 3. What is red is a Gleason 4. If we perform a target biopsy, of course, we stick the needle in the most aggressive area. So we tend to stick 3 cores as index sample, all taking the Gleason 4 part. Therefore, the final histology report would be Gleason 4+3. But instead, if on the same patient we do a standard biopsy, we stick the needle on the left, maybe just on the 3. So that one will have only Gleason 3 pattern. The needle in the middle will be on the Gleason 4, and the needle on the right will be just Gleason 3. So in the last example, the patient will be diagnosed with standard biopsy with a 3+4. And this explains the huge variability. All this concept to bring the evidence that we are now currently using the new technology, MRI before biopsy, we're using it in the guidelines. I love performing in-bore MRI guided biopsy, so I'm a strong supporter. But we have to take into account that all this new technology has an impact on management, because some patients that were previously classified as a low risk, now they're shifted into intermediate risk, and from active surveillance, maybe they receive a surgery. Patients who were diagnosed as a favorable intermediate risk, now we find a more aggressive feature, so maybe our surgeon perform more lymph node dissection. And last but not least, we must point out that the risk classification, as we learned since we're children, like the micro classification, EIU classification, or NCCN classification, are not validated with the target biopsy results. So all the risk calculator, for example, must be updated with the new evidence coming from the target biopsy. Last but not least, I want to say one thing regarding the patient acceptability, because there are hundreds probably paper comparing standard biopsy, fusion biopsy, inborn biopsy, and we decided the biopsy according to our availability, knowledge, what we think is best, but no one asked to the patient which system he prefers. And this is the driving. That is why we are running this study on the acceptability. We give to the patient a questionnaire with 11 questions, and the patient scores in a very simple way from 0 to 10, 0 not acceptable at all, 10 very acceptable. And we did in our pilot study in 47 patients who underwent inborn biopsy, and the patient had a very good feedback about the technique. They have perceived very high utility of the technique, and they complained about the pain at 21%, motionless, and surprisingly, they compared only 4% of them complained about the duration. And what is interesting, out of these 47 patients, 24 had before a standard biopsy. In all questions, we got far better scores in terms of acceptance for inborn MRI biopsy than for the standard biopsy. And 70% of them expressed their preference that they would prefer to repeat inborn biopsy rather than standard biopsy if necessary in the future. Thank you, and I'm here for your questions.
Thank you so much, Dr. Petrolia. That was a very interesting talk. I have a quick question. We have a couple of others, but I would like to ask you, on one of your slides, you had the upgrade and downgrade in pathology after your actual inborn biopsies. And I was wondering what your thoughts are on inter-observer variability on pathology. I mean, we always look at different readings from different radiologists on pirates. We do everything to quantify something that I think is a more subjective view on this, but the same applies to pathology, right? So how much of that do you see also playing into upgrade or downgrade of those results?
Okay. And thank you for the question, because it's a beautiful question. And I entirely agree with you, because I always say that radiologists and pathologists do the same job at a different size. But and we do mistakes, they do mistakes, we have a huge variability, they have a huge variability. So as a general rule, this always applies. For the particular case of our data, it may not apply, because all the reports of our inborn MRI guided biopsy are performed by a single uropathologist with 30 years experience of prostate MRI. Because since it's a new technique, we put a lot of focus, scientific focus on that. All the inborn MRI guided biopsy are reported by a single, by the most experienced pathologists. So my data are not affected by inter-observer variability of the pathologist.
Okay, well, I wasn't so much wondering about the problems with it, but more how that would play into some of the results if you would have a rereading of some of the initial biopsies. I'm sure you would potentially get an upgrade already from a 3+3 to a 3+4 with a different pathologist. So therefore the upgrade might not be as much. So I just think we sometimes tend too much to try to quantify something that isn't necessarily quantifiable in every single case, and really is more dependent on some variability by the observer.
Yes, of course. But still, you see, overall, our overall upgrade was 30%, which is exactly in keeping with the literature. So this.
Oh, I think that.
I wanted to highlight this because I think we have to address scientifically this point, the 3+3, because we probably don't see with MRI small foci of Gleason 4. We don't see with MRI, and therefore we cannot stick a needle there. But at the final histology on the unfoldment section are still seen. So what is the relevance of that? I do not know. But it's something which stimulates our brain to do further research.
Yes, there definitely is more research needed, but I think those results were already very impressive. I'd like to bring in my colleague Martijn, who's our clinical collaborations manager. He went through some of the questions and maybe can
Yes, please.
ask some of those that have been coming up.
So yeah, there were many questions coming in now as well, so that's really good, of course. And one of the questions we always get is, of course, that in-bore MRI biopsies are generally performed by the radiologist. Also, many of our users are generally the radiologists, but of course the patient comes in with the urology. So how is the balance with the urology, and how do you involve them? How are they involved with the in-bore biopsies?
Yes, now I can comment on that because now we've been doing in-bore MRI guided biopsy for the last 6 years. So we learned each other how to deal with each other, urologists and radiologists. So basically, the first biopsy naive is mostly performed by urologists because they do systematic plus targeted, and they do fusion biopsy.
Yeah.
So we are like a second level. When there is a very suspicious lesion, it is discussed, a very difficult lesion for them, it is discussed at the MDT and the biopsy naive. We only do selected biopsy naive, or if the patient has had a previous negative biopsy, but the MRI is positive, in that case, we do in-bore biopsy. So we share the market.
Okay.
It's not, if that was the question, we share it.
Yeah, so after the biopsy, the patient goes to the urology again.
There's no competition, because on the other hand, we do not have space, human resource, or time of MRI to do all the first biopsies. So I think it's a fair way to deal. But we, on the other hand, have to say that we, the radiologists, we perform the in-bore MRI guided biopsy, and they, the urologists, they perform the fusion. So we don't mix.
So thinking about the future, do you think that eventually all patients will be done with targeted biopsy only? And will that then be done in the MR, or will it be done in different ways?
That is a possible scenario. And that is a possible scenario, but then we face the problem of MRI availability, cost, because now it is a selected, we do on selected patients. The majority go with the standard fusion and so on, and we do on selected patients. Maybe in the future we will do more, probably we will do more. Also because I can tell you, I always listen to the patient, and patients love to get a few courses on the lesion. They always ask, why should I get samples on the right side if my cancer is on the left side? So, but it's a process. The process has started. We will see. We need evidence. So, in my personal experience, I just follow the guidelines.
Okay.
And how is the collaboration with urology in Spain for you, Dr. Villanova, to maybe add from a different perspective? You started also to do in-bore biopsies. You're still muted, sorry.
Yes, from my side, I have to say that when I announced that I was able to perform target biopsies on MRI, I have to say that a lot of urologists were very happy. And the reason is that it depends because on how is management on different sites. And for instance, here in Girona, most of the biopsies are being performed by the radiologist. So it's not very, very common that the urologists perform biopsies. So that's the reason that they were very happy, because at that point, when they have a patient and they were going to indicate a biopsy for, of course, as Dr. Petrali has said in the MDT, and we discussed, but of course, at the end, we are the ones that are going to perform the biopsy. And there was one question here, and who is performing these biopsies? And of course, it's the radiologist because he's the one that is taking care of the MRI. So in this case, there is no doubt that we are the radiologist performing the in-bore biopsies, as you already said. Yeah.
But there's always a collaboration with the urology to.
Of course, because the indication has to be discussed to the proper indication, and the indication, of course, most of the times has to be the urologist that is going to provide the request of a prostate biopsy, of course. Otherwise, it's not going to be any request.
Yeah.
There also was a question that I would like to ask both of you about what needle to use, whether you use a standard needle or whether you use an MR-compatible needle. Maybe Dr. Petralia, because you have the experience with both, I believe. Your thoughts?
Yes, I can tell you, I've been using from the beginning the MR-compatible needle, which were extremely useful with the manual system, because the manual system, in my experience, was less precise, so I had the opportunity to scan, to acquire images with the needle inserted. So I was able to see where I was going. With the new system with Soteria, it's not necessary, and we have tried other non-MR compatible needles with similar results. So there's no need at all with the Soteria system. I trust the projection that it is performed. Now, after hundreds of cases, I trust the projection that it is performed by your software. You know very well that at the beginning, I was quite skeptical, so I needed to do my own experience. Now I can trust it. But you know, you have to be confident on what you see with your eyes.
You would like to have the experience.
Yeah.
Dr. Villanova, you started from the beginning with the stainless steel needles, correct?
Yes.
Yes, I started with stainless steel, and now I'm ready. I'm using also the non-stainless steel needle, and I'm happy, still happy.
Okay.
Any other questions, Martijn, that have not been answered
So
yet?
we have another question. So are there special contraindications for in-bore MR-guided biopsies in regarding of selecting the patients?
Well, of course, as any transrectal biopsy, you need antibiotic preparation, of course. But if you do a proper antibiotic preparation, we have less than 1% in our experience. So it's not a big problem. It's not. Also, there's a lot of discussion on this. There are people who call it transfecal instead of transrectal, transfecal biopsies. I mean, I think it is not the case. In personal experience, I have just a few cases over hundreds, and so it's not a big.
Maybe from our perspective, experience with different users in different markets, all the patients have definitely received a diagnostic MRI, so there shouldn't be any contraindications to MR in general. And a lot of them also have received previous ultrasound biopsies. So that would mean that there shouldn't be any contraindications for those patients, but those would be similar in those two settings, I believe. Yeah. There is just a new one coming up, Martijn, I think. Oh, the rate of complications for MR-guided biopsies. That's an interesting one because we hear that all the time in the context of transrectal biopsies in general. Maybe your experience, Dr. Petralia, with a large patient number, and then Dr. Villanova for his recent experience.
You know, I did not publish or I did not close the data, but I can anticipate that we had no bleeding and no other major complication. We had one patient who had for like unconsciousness for a few moments, because you know, as a vagal syndrome, you know, when you wake up and then you fall down, this happen, and no bleeding and less than 1% sepsis.
Yes, and Dr. Villanova, did you have any
result? Well, since you know, I have performed a 35, and the only complication I had, it was a rectal bleeding out to self, and that's all that I have as a complication. So no any other.
And if there are any complications, so is then the patient will come back to you, or will they go back to the urologist, or how is that arranged in your hospital?
Well, we provide all the information, and whether any reference, then we provide to go to the emergency, and then we go to the urologist. That is the reference. That's we have all the protocol in case that, of course, there is some incidents, of course.
So therefore, it's also the collaboration again with the urology.
Yeah, of course.
Yeah.
Yes, the all cases are discussed, so
yeah,
they're common patients.
Okay. There was another question regarding training, of course. So with the biopsies, Soteria already always provides training for the biopsies itself, but I think there's also a lot of training for just MRI imaging reading. There was a lot of courses. I want to mention as well that Soteria is also going to provide different courses together with Petralia and Villanova in the future, so we keep track of that. But for now, just maybe Dr. Petralia can give some answer on what is the need of training for MRI prostate and maybe as well prostate biopsies.
Well, I can tell you that in our experience at our center, that the training with the robotic system is shorter because it's easier system. So we had a good feedback. You came to our institution, we have young doctors, residents, and the training is much lower. I would say like in the range of 40, 50, you are top level. Okay. So it's not a big learning curve. So it depends how much time you cover this number.
Okay.
For someone who is a beginner.
Yeah. So for you, Dr. Villanova, because you didn't have any experience with the in-bore biopsies before?
Well, I spent 4 hours with Dr. Petralia, and then just 5 weeks with Soteria and my site. And the 5th day, we started performing biopsies. And the next week, I did my first biopsy alone. So, of course, with the support of the system of Soteria, and nowadays it's quite easy as we are performing a web seminar online. So I had the support, any biopsy that I was performing at the beginning with online support. The learning curve for my site, it was quite fast, yes.
Okay, that's very good to hear, of course.
Okay, I think any additional questions we will gladly follow up later on, because I know Dr. Petralia is under immense time pressure and we already went over time. But I very much appreciate both of you taking the time and presenting those fantastic talks to us. We will follow up with all participants, provide the links to the talks. Please register for our next webinar on June 18th, where we will be doing some demonstration of the system. If you have any questions, please contact us. And thank you again so much, Dr. Villanova and Dr. Petralia. And I hope everybody enjoyed the talks as much as we did.
Okay, thank you very much.
Thank you very much, everyone.
Thank you very much.
Thank you for your attendance.
Thank you.
Thank you.
Thank you. Bye-bye.
Thank you.